Because the talk from Sophie was about the scientific research that we did, and now I want to try to take these knowledge into your mind and then translate it to the clinical practice. Because I am not only working at the Department for Scientific Research, I'm also working at the ambulatorium, that is the clinical department of the university, where I see children with triple trisomy X, also Klinefelter, and also other children that have difficulties in daily life. And I'm used to think what I'm trying to unravel why these children have these problems, and think of what they need in their daily life. So I'm both a scientific researcher, I'm a clinical worker, and also teacher at the Leiden University. And my challenge is to translate the knowledge from the scientific research into the clinical practice, and to use the knowledge of the deficient brain behavior relation or the compromised development to assess the strengths and the weaknesses of an individual. So now we stop talking about groups, but try to talk about individuals, individual children with trisomy X. And we are trying to think what are their specific needs for this individual. And to do this, we use the same framework that we use for scientific research, where we try to find the underlying mechanisms to explain the behavioral problems that they cope in daily life. But we also use this model when I see a child in the clinical practice. When parents come to our clinic, I noticed that there are two types of parents. The first type of parents that are the parents that have concerns about their child, because during pregnancy they discovered that their child has trisomy X, and that's a different type of group from the people that come to us and say, well, I have this child and it's struggling with certain aspects of life, and we want to know why that is. And afterwards, sometimes we discover that this child has trisomy X. It's a different kind of group because they have different questions. The common concerns of the parents that of the parents with children diagnosed prenatally, they have questions like, my child has trisomy X, and what does that mean for her? How will she develop? What kind of difficulties will she have? And also, what kind of possibilities will she have in her life? And how can we help her with the things that are difficult for her? And a lot of people struggle with these issues because when they go to the medical center, where they get this diagnosis, the information about trisomy X is mostly about the medical issues. And I hear a lot from a lot of parents in the Netherlands. I don't know if it's different here in Norwegian, but they don't inform the parents quite well what the psychological aspects are of trisomy X, because there is not much knowledge about it in the Netherlands, and the people have to come to the specialized clinic, like the one in Leiden University, to know these things. So it's difficult for these parents to know what to expect. And on the other hand, it's also difficult for them because the developmental and the behavioral outcome of these girls is very variable. So you know that you have a child with trisomy X, but how she will develop is a big mystery. The other group of parents, they come with concerns about their girl, mostly not knowing that she has trisomy X. And these parents come to the clinic and come with questions like, my child has difficulties with learning, behavioral problems, or problems in school functioning, mostly on these 3 areas. And we don't know what's going on. We have the feeling that she has these extra difficulties, but we can't get to it. We can't understand why she has these difficulties. And can you help us to understand these difficulties? So then we have a different point of perspective, because on the one hand, we know that there is a specific genetic makeup, and in the other group, we don't know that yet, for sure. And we have to analyze it by looking at her behavior or at her cognitive functions. And that is quite difficult, because in the second group, where we don't always know that the child has trisomy X, there is a lot of correspondence between the behavioral profile of children with trisomy X and children with other childhood disorders, like autism spectrum disorders or language disorders, ADHD, learning disabilities, or mood disorders like anxiety or depression. So there is a lot of correspondence between the behavior, but the underlying mechanisms can be different. And in some cases, the underlying mechanism that can explain these difficulties is trisomy X, but sometimes there are other explanations for that. And but the behavior that these children show is quite the same. And when you have this child that has a lot of dealing with problems in her life, it's difficult to recognize a girl with trisomy X, because the physical appearances and the physical features are minor. This is a graph from research from Tartaglia, and they found that the most common physical feature is the stature. It's 90%, about 90% in the highest rates of the length, and but most people aren't aware of that and just think, well, this girl is tall. It's quite obvious that you think that. So there are minor physical characteristics, so we have to take a really good look at their behavior. So to determine the severity of the concerns as a parent, and that is mostly for the first group of the children that are diagnosed prenatally, parents want to know how much concerns do we have to have for this girl. Will she develop fluently, or will she struggle in life? So these parents want to know what the severity of the problems are. And the other type of the parents want to examine whether or not the child has a right diagnosis, so we can know which interventions we have to plan for this child. So we are looking for the signs to pay attention to, and that's knowing which signs to pay attention to. That we know from scientific research. Then we can use the knowledge from the scientific research. First of all, we take a look at the behavior. First of all, we want to know whether or not the behavioral problems are severe or not. Oh. I'm sorry. I thought there was another slide. When we look at that at the behavioral level, we have certain domains where we have to pay attention to. And the first domain is the motor development. And most children with trisomy X, they learn to walk on the average with 16 months. So that's a bit later than children without trisomy X. That's about 12 months. But as you can see, the range is between 11 and 22. So some girls with trisomy X walk at 11 months and some with 22 months. So it is difficult to know because typically developing children can also walk at 14 months, for example. But if it's later, it might be a signal. Another signal on the motor developmental level is difficulties with coordinating motor skills. So learning to swim or eat with a fork and a knife, because these motor skills are very complex. Because, for instance, when you swim, you have to coordinate your arms and your legs together and not round. And that is quite difficult to learn, and it may take the child for a longer period to get to sorry? Learn. Yeah, learn is also, of course, to learn these these skills. Also, the handwriting can be difficult to learn how to write, and also the handwriting can be of a bad quality. There can be decreased muscle tone and the motor planning difficulties. And that is, for instance, when a child tries to reach for something and she just misses because it was difficult to plan her motor actions. So some girls have these difficulties in planning their motor skills. There's another important domain, and that is the language domain. The girls with trisomy X have an overall delay in the language development. They have a delay in the speech development. Most of the times, the girls talk their first words within 18, 19 months. But also there is a big range between 12 months and 40 months. So that's also really very variable. They have reduced receptive language skills, reduced expressive vocabulary, and verbal communication problems, which we also saw in the presentation of Sophie, and verbal intelligence, because the intelligence is divided into two different domains, the verbal domain and the domain of visual information processing. And the domain of the verbal intelligence is mostly affected. And a lot of children with trisomy X have speech therapy in their younger years. What can we see about their daily behavior? we see that they have difficulties with focusing their attention, and they are distractible. That can be at school, but it can also be at home, of course. We see that they have poor organization skills. You can see that at schoolwork at school, but also at home. For instance, difficulties with dressing, with, for instance, what to put on first. But also planning to go to school, which things you need to go to school, for instance, and how do I plan to go there? Which tasks do I have to eat? I have to dress up, I have to do my hair, I have to pack my things. And you have to plan that in the right order. And some girls have difficulties doing this. And for instance, some have a really messy room, because that is also a sign that you have difficulties in organizing things. When we look at the learning development, here's motor development. I'm afraid that's wrong. At the things that are the trisomy X girls have difficulties at school, and mostly is about reading and also language problems. And we see that a lot of them have special assistants at school, for instance, remedial teaching. And 12% go to special school. So they need special surroundings at school. When we look at science, where we have to pay attention to the social, emotional development, we see that these girls have a social interest, but they have difficulties in forming their peer relationships. They are socially withdrawn and shy. And when we look at the emotional signs, they might be persistent, but they are friendly but socially sensitive. Emotional and socially withdrawn, we saw that before. They have less self-esteem. Some of them have mood disorders or depression, and some that might be severe or mild. Some have these certain anxieties, for instance, social avoidance or a general anxiety for all types of things in daily life, and specific anxiety like separation anxiety. And they have difficulties forming peer relationships. So these are things that in behavior that we have to pay attention to. And how do we do that? That information we get mostly from the parents, because it's observable behavior. And we assess that by questionnaires that can be filled in by the parents or by the school or by the child herself, but also by observation. So we go to school or at home and, for instance, take a specific look at the social interaction processes that this child shows. So now we have information of a child on the behavioral level. But with neuropsychological assessment, we can also take a look at the cognitive functions, because we want to identify the underlying explanations for these difficulties in daily life. And therefore we have to assess the child's cognitive functions. So now we take a look at the child herself. The first thing that we mostly do is look at the intelligence profile, because sometimes a certain profile can tell you what strengths or weaknesses a child has. But after that, we want to do some specific assessment on different kind of cognitive processes, because then we can understand what are strengths and weaknesses, so we can explain the behavior that this child is showing. And the areas that we assess are attention, visual motor abilities, memory, and not one type of memory, but all the verbal memory as well as the visual memory. Executive functions like inhibition, how much control does this child has over her impulses, planning and organization skills, so we have some difficult problems for this child, and then we say, well, can you find a solution for this? Can you think of a certain strategy to cope with this problem? And if this problem doesn't work anymore, are you able to switch to another alternative strategy? So we take a look at these kinds of skills. Of course, we also have a specific attention to the language abilities, and we look at the expressive abilities, but also the receptive abilities. And of course, very important, the social cognition skills. So does this child has a problem with face recognition, for instance, or emotion recognitions? And what about the comprehensions of complex social situations? So we show them social situations, and then we say, do you know what's going on? And do you know how the different people are feeling, or how the one reaction of this person influences the reactions of the other persons, for instance. So we have all these different domains, and we want to know how this child is doing in all these domains, and then the output of all this is a profile of strengths and weaknesses. And the most common profiles of cognitive difficulties for the girls with trisomy X, that is an average to below average intelligence profile, poor visual information processing, attention problems, verbal learning difficulties, verbalization problems, organization skills, inhibition problems, mental flexibility problems, and social cognition problems. And that is what we also saw at the scientific research to these children. And when we see this type of profile, then we might think, well, maybe this child has trisomy X. So sometimes when we see this profile, we recommend parents to go to the hospital and find out whether or not she has trisomy X or another X chromosomal disorder, of course. And when we have this profile of strengths and weaknesses, that tells us what specific needs this child has. Unfortunately, there is no evidence-based treatment for girls with trisomy X. It just doesn't exist. But we think from scientific research that the psychological treatment should include language training, motor training, executive functioning training, and social and developmental issues that have to take care of in order for a girl to have less difficulties in daily life. But we have to take age and the developmental period into our mind, because Sophie told us that certain domains of the brain are critical at the periods, some periods of time. So it's important that you keep age in mind, so you know what are critical phases, and those phases have to be put interventions on first, and others later, perhaps, in life. Well, if we are going into a treatment process, first of all, we have, of course, the parents. And when I sit with parents, they tell me that they have really got difficulties of how do they tell that their child has trisomy X. First of all, to the child itself, of course, but also to teachers or family and that kind of things. From how much do we tell the surroundings and how much do we tell the child herself? And there was a scientific research from Dennis. And he had some 139 parent surveys analyzed, and all about the question, how should I tell my child? And they found out that the most common concerns of the parents were that the child will feel different and it will affect her self-esteem. They were concerned about how the child will react. Some had discussions about they were have common concerns about discussing infertility, but that's mostly the boys with the extra X chromosomes. They have difficulties in knowing what to say, which word to use, and making the conversations age appropriate. What can she deal with? They are afraid that the child will not understand and that the parents, your own emotion will interfere in this conversation. Some were troubled by the private concerns and are afraid that the child will face discrimination, or the child will use the disorder as an excuse. Some parents were worried about what is the right time for the diagnosis and how do we discuss the medical problems. And the scientific research showed that the children that were diagnosed prenatally were told during childhood. Just most 90% were told during childhood and almost 10% during the teenage years. And I come across parents who haven't told their son with Klinefelter syndrome when he was 16. And it was quite late, I think, because he has this hormonal treatment, so he has his injections. And he was already 16, and then he heard that he has Klinefelter syndrome. And that was quite difficult for him to deal with that, because his parents knew all his life, and he was really bothered by that. The other group of children that were diagnosed during childhood, they were told at the time of the diagnosis, mostly, almost 100%. Yes. I'm going to skip some slides because it's almost time. But I think it's important that we also, as from healthcare providers, think with parents what to tell the child and what is age appropriate for the child to know. And most parents frequently pointed out that the child has to face challenges and has qualities that makes them unique. And they had highlighted the child's strength and explained that they would help the child when facing these challenges. That was the most common conversations they have with the child. And Dennis had some recommendations about telling the child to use straightforward terminology, and, of course, developmental appropriate language. And he recommended to tell that it's not contagious. And you can see in the different slides, and I skipped, that only 80% of the parents told the child that it is not a contagious thing, which from a parent point of view is quite logical, but I can imagine from a child's point of view that you think that it is contagious to other people. So it might be quite good to tell that it's not contagious. Also have to explain that it is no one's fault, and you have to tell how it has happened. You have to tell that it is a lifelong condition. And Dennis recommended that you have to be cautious with the term sex or sex chromosome, because it can confuse the diagnosis with their sexuality, and that might confuse them and think that they are sexually abnormal. So I don't know what the Norwegian words are commonly used with trisomy X, but they recommend not to use sex or sex chromosomal disorders.
We use the term triple X.
Oh, okay.
Yes.
Yeah, so that's not a problem
No.
here. Yeah, but maybe when you explain how it works, then you may be cautious that don't work sex too much. When we look at the treatment for a child, in the early development, you have to, when a child has these speech problems, you have to get speech therapy or physical therapy. But when the child is older, you have these other interventions that can be necessary. For instance, educational learning, social treatment, focusing on what is important, and psychological treatment, focusing on anxiety and how to be more confident, because that is something that is, I, from a clinical point of view, is very important. That no matter whether you have trisomy X or not, the most important thing is that the child feels confident and can be who she is. And I think that is very important, that that her self-esteem is good enough to cope with things in her life. And for the older children, I think self-management training is very important, because when you get older, you have all these extra demands of, for instance, living for yourself, getting a job, for instance, and you have to cope with all these difficulties in your daily life, and you have to manage yourself and control things, because if you, for instance, have difficulties in controlling your emotions, then that might lead to difficulties at work. So if you learn these girls how to manage these problems by themselves, they are better in dealing with these daily life difficulties. I think I think you can read these kind of examples in the slides. How and the main message of this is that when a child has a lot of anxiety, you have to there are different kinds of aspects, the way you think, the way you do, and the way you feel. And the way you feel is very difficult to change, because if you are anxious a lot of the time, so it's difficult to change that. But you can intervene in the way you think, or the way the things you do, and if you intervene on that, they might be less anxious, for instance. And if you see that the child is very tensed because I think that trisomy X girls are most of the time, a lot of the time, very anxious. I think it's important to recognize when she is getting more tensed. And that is especially for her parents, but also for herself. And I think that parents could help these children how to be aware of these emotions and to signal that first on forehand, because it might go stronger and then they feel really anxious. So I think that you can help your child with recognizing feelings of tense or anxious or depression or anger, and then you have to label it for the child. For instance, you can say, I can see that you are scared. I understand it because this situation is new for you, but you will get through. I think a child with trisomy X has difficulties in labeling her own emotions. So more than other parents, you have to label it for the child and recognize that it is okay that she feels anxious because it's explainable, because this situation is new for you and you have difficulties in coping with these situations. But you will get through, because other times you also got through. So I think that as a parent you can help your child in this type of way. Also, for instance, I can see that you are mad. I understand it because you really want this, but it is not possible. So you can recognize the emotions and label it for them and tell them what to do with it. And the things a child can always do is to try to relax and use breathing exercises. So sometimes I also work with children to teach them how to relax themselves, so they have better control over their own emotions. And sometimes they have to pay attention to certain bodily expressions or feelings, and they have difficulties labeling this. So I think we have to help these girls with these difficulties. And thinking, it has a lot of impact on how you feel. So when I am sitting with trisomy X girls, we are making lists of the things that they can always think. And you have, when you think positive, empowering thoughts, they might feel better. So if you think more often, I'm a very nice girl, or although I find this hard to do and I feel tensed, I know that I'm good at other things, or I know that I need more than others, so I have to take that into account. So that's that's a realistic thing. Well, I have these difficulties, I have to take this into account, and I have to deal with it and cope with this in my daily life. But these are powering thoughts, and that might influence how they feel. And they also, a lot of girls have difficulties in social interactions and understand what is going on, and for instance, know what subject the conversation is about. I've talked with a lot of girls and boys with extra X chromosomes, and they just tell me, I'm in this conversation and I have no clue what people are talking about. I have no clue what the subject is, and I have difficulties in reading their emotions. So I have no clue how to react on that. And then we come up with phrases what they can say at that moment if they don't know how to react. But you can also always say things like, can you tell me again? For instance, if you need more time to know what subject the talking is about. So, ways to feel better is to relax and to breathe and do breathing exercises. Stand firm, then you feel stronger and more confident and think powerful thoughts. And in this way, you might help these girls to cope with daily life issues. And I think from parents it is important to help your child to recognize these emotions and tell her why she is feeling this way, because she might not know herself. Just give words to her emotions. I think that is really important. Well, it is a bit in a rush, and I had some examples, but I'm afraid that there's no time left. So I hope you have some questions, perhaps.